So what I'm going to talk about today is looking at the gendered effects of COVID-19. And I should start by saying when I talk about gendered effects, I basically mean women. And I know that it's not a binary discussion between men and women, and there are other gender considerations we could be talking about. But what I'm talking about today is where are the women in the outbreak of coronavirus and the economic and social effects of the response efforts to mitigate the risk posed by coronavirus. And so the starting point for this discussion that we're having today, and please do interrupt me with questions at any point. I'm more than happy to take questions at any point. Oh, was that stopped?
Yeah, let's let your screen shares come down.
Oh, sorry. My bad. Is that working now?
Yeah, that's it.
All right. So the starting point to this is thinking of a feminist theory to health. And so I always think this quote is quite an important starting point to just get to the position of where I'm coming to this discussion from. So if we're thinking about health security and health emergencies, right, this quote says we need to understand the state of health security for all people, and we need to understand the embodied realities of people's lives that result in health security for some people and insecurity for others. And this means drawing attention to the narrowness of the discourse of global health security that renders invisible actual people who are impacted by the emergencies, and illuminating how current ideologies and structures of governance shape the life chances of individuals the world over. And I think this is particularly important given all the discussions that have been happening around the end of lockdown, right? There's been so many discussions between, we've got to reopen the economy and think about the impact of the economy and the impact to labour markets and the impact to all the different other aspects of society we need to think about. But if you take a feminist approach to looking at this outbreak, you're not going to be thinking necessarily about that, and you're going to be putting at the centre people. Right, and taking the central unit of analysis to be people and the effects of the outbreak on people. And this is a gap in health policy around outbreak response. So there's this real lacuna in global health emergency policy, global health security policy, to recognise people, and within that, to recognise women. And that women and men are often differentially and disproportionately impacted by outbreaks, and to recognise the burden of response efforts place further limitations on women's activity. So if we look at the main policy responses at a global level to health emergencies, the list on your screen here includes some of the big ones that we see in the World Health Organization. We have the International Health Regulations, the Joint External Evaluation, the WHO Research and Development Blueprint. We can also look to the Global Health Security Agenda, to the Biological Weapons Convention, and then national policies such as the United States Global Health Security Strategy, the United Kingdom's Health is Global Strategy. And none of these mention women. None of these mention gender as a variable for the impact of outbreaks and how it might affect men and women differently. So this to us makes, to me and to colleagues who work in gendered response to outbreaks, makes us recognise that this is a problem. And it isn't just within policy, but it's also within the academic space that, we've seen major academic reviews of major outbreaks, such as the Harvard LSHTM panel on West Africa, the Stocking report, also fail to recognise that women and men were impacted differently. So this is the sort of starting point, right? But if you have a gender neutral policy, does that mean that we're going to see a perpetuation of differential impacts of men and women in this outbreak of coronavirus? So what I want to talk to you today is about, well, how can we see this emerging even in the early days of coronavirus? How can we see these gender differences starting to emerge? And why is this important? Well, Cynthia Enloe says that taking gender seriously not only adds to analysis, but it also can produce different analysis, which again I'm hoping to show you today. that it starts asking different questions, even of the same data sets, right? And this allows us to disaggregate the effects of policy on different people, right? And so what I want to do, and with colleagues who are currently working on this project, right, with me, looking at a rapid gender analysis of the coronavirus response, is to try and move beyond a very narrow focused global health emergency response package focused on prevent, detect, respond. And that's, can be seen in many ways. It's similar to the UK corona response policy based on, delay, contain, delay, mitigate, and recognise the unequal burden of infectious disease on women. And I argue also that this hasn't really occurred yet in the outbreak. Now, whilst I think there has been a sea change from previous outbreaks, so certainly during the Ebola outbreak in West Africa, the Zika outbreak in Latin America, women weren't part of the conversation and they weren't part of the decision making. And what we have seen in recent months is actually that there is a lot of discussion going on about the impact on women of coronavirus. But we haven't seen this manifest in policy yet, right? We haven't seen it move from discussions on social media, pictures and discussions in the media to actually move into meaningful policy change within the global or within most national spheres, with some exceptions that I'll come on to talk about. Instead, what we're seeing is a heavily gendered outbreak because of the policies which are designed from a very gender neutral perspective. We're seeing, global efforts to recognise women as heroes, particularly in their role as frontline healthcare workers, as taking the burden of care responsibilities on formally and informally. And in doing so, this further reinforces gender inequalities within society. And so we propose, or our hypothesis is that if you put women at the centre of health security policymaking processes, we would see a different response to the outbreak, and one which would prioritise different people within society. And so this is almost a thought experiment to see, why do we create policy in a certain way, and what are the effects of that approach? So to begin with, I thought it was important to look at some statistics. So these are reported coronavirus 19 cases by age and sex. Now, as you'll see, if you are a rapid maths whiz, you'll see that this doesn't add up to the total sum cases, whatever we're at as of today. This is taken from the UN Women data set, which has been trying to create sex-segregated data for the outbreak. And it's really struggled to do this. And so far, they've only been able to get sex and age disaggregated data for about 450,000 cases worldwide. And if we're now, I can't even remember where we're at to now, it's a very small percentage of total cases. And this is the first issue when we think about gender and women in outbreaks, is that we simply don't have the data to know. And collecting sex-segregated data isn't prioritised within the global health security infrastructure. Now, we know this data is being collected. We know that every hospital, every time you go to hospital or see a healthcare provider, that data is being collected somewhere. But it hasn't been considered to be a policy priority to make sure that data is publicly available. So this is the first concern we have. During the Ebola outbreak in West Africa, this data also wasn't actively collected or analysed until the second year of the outbreak. And in doing so, when it was finally analysed, there was seen to be a slight skew towards infections of women from the ages of 25 to 45. And it soon became clear that this was because of the caregiving role they were doing within households, and this could lead to more targeted interventions to ensure that mothers effectively knew how to, when knew the symptoms, knew when to seek health care, and also knew how to protect themselves if they thought that or suspected there was a case within their household. And so actually having this data can lead to better public health responses. What I think is interesting about this data set on your screen right now is that whilst for the most part it looks sort of balanced, right? It doesn't look like there are massive gender differences. I think the bit that interests me in this graph is looking at the age bracket of 20 to 29. And we are seeing a bit of a difference between men and women here. Now, this to me makes me question, well, who are those women? And is there an overlap between women in this age bracket and infections and healthcare workers? So this is why it's so vital that we have this information. Because if you look at this, so there's some data that was done by Autonomy, some research that was done by Autonomy, who has tried to map along the x-axis the share of female employment, and on the y-axis is looking at risk of infection. So it's basically showing you that it's women predominantly who are in the riskiest jobs when it comes to infection with coronavirus. It's health professionals, health associate professionals, and care workers who are the ones who are the essential workers and account for at least 7 in every 10 workers in this category. So that's why it's so important to understand the role of women in this, because they are performing most of the frontline healthcare work. And so we know that healthcare workers represent 70% of the global healthcare workforce. And so not acknowledging this explicitly, the role that women perform, makes them invisible, right? And so we need to really focus on that. And I know that some of you may have followed the debates that have been going on in the UK around access to PPE for women, and how PPE isn't, well, it's one, at the first point it's scarce, there isn't much of it, but that it's been designed to fit male body shapes, male face shapes. And actually for a lot of women, this simply isn't really working. It's covering too much of their face, and it's having, broader impacts on their work experience than is necessary, and or might be putting them at excess risk of infection because there are gaps exposing their mouth, exposing their face where they might not otherwise have to. So not getting this data, not recognizing that women do perform most of the care roles in the health sector and therefore at most at risk of infection, is a glaring omission to a policy response. And maybe the reason that policymakers aren't thinking about this is that simply the data isn't being provided to them, right? And they aren't necessarily thinking that, disaggregating it in their own minds in that way. And so the failure to be able to actually produce meaningful sex-segregated data sets has much broader ramifications. I feel like I've labelled my point here, but I think it's really important. Because if you do look at healthcare workers' infections, they are predominantly, as you might expect, amongst women. So this is the data, well, this is where we do have data, sex-segregated data, and data which is disaggregated by labour sector. You see that, as you might expect, if 7 out of 10 healthcare workers are women, we see that similar rate of incidence of coronavirus amongst healthcare workers. So we really need to focus on this and put it at the front of policymakers' minds that it's not just healthcare workers, it's women healthcare workers. And it's also not just women, but as another branch of feminist thought tells us, that intersectionality recognises that women are not identical, but that gender also intersects with additional drivers and inequalities, additional drivers of inequalities and social determinants of health, including race, religion, ethnicity, location, disability, and class. And when we look at that, this is the latest HSJ data from healthcare infections in the UK. Sorry, not healthcare infections, mortality amongst healthcare workers of coronavirus in the UK. And so then when you look at that, you see a really stark percentage of who is dying of this outbreak. And I'm sure some of you might have seen the statistics that came out today from the Office of National Statistics in the UK, which have shown similar stark contrasts, demonstrating that BAME populations are dying more of this in the UK. And whilst I know that the UK government and Chris Whitty has launched research proposals and research activity into trying to understand what are the drivers of this and why is it that we're seeing more BAME populations die, I think one of the key things you can learn from feminist approaches to health and health emergencies is that there's a lot of structural factors here. right? And we know that BME populations experience worse health across the board. And so again, taking a feminist approach allows us to understand that and to try and incorporate that into our policy making to mitigate against some of these inequalities within the system. But thinking about care and healthcare workers, we also need to understand when we talk about the impact of outbreaks on women and the impact of coronavirus on women, is that care is not just formal, but we need to understand the informal care sector to be able to understand the impact of the outbreak on women. So feminist international political economy focuses on social reproduction, which refers to those household activities central to production and reproduction of life and capital or economic contributions. So these include, but are not limited to, the gendered roles in child rearing, caring responsibilities, small-scale agricultural labour, household work and maintenance. And this role of the informal care sector and social reproduction within households has also been dramatically impacted by coronavirus. So we know that when schools shut, who is doing the homeschooling, right? Who is doing the additional unpaid labour within households to look after the children? This picture that you can see is actually in my attempt of homeschooling. This is my daughter, and we were doing oceans. So we even in my household where I, push for gender equality, I am also finding myself similarly doing homeschooling. There are also additional domestic responsibilities, cleaning, cooking, and even just the mental load for managing all of this, right? Who's deciding when we need to go to the supermarket? Who's deciding who's doing the homeschooling today, for example, and what they're doing? And we know across the world, almost exclusively in every country, that gender norms presuppose that women will pick up most of this load. Now, it's not necessarily simply cultural norms of behaviours, but it's also linked to, well, who's got the flexibility to be able to drop the work, right? Or who be able to the more flexible jobs. And we know that women are more likely to be in the more flexible jobs. Women are likely to be in the lower paid jobs, which is why, the gender pay gap is such an important thing, because you get to moments of crisis here, such as we are on the coronavirus. And if you have two partners in a household, it's probably going to be the one who earns less who takes on the additional burdens. And so that's given gender pay gaps, that's likely to be women. And that's why it's quite surprising from the UK that the UK government at the end of March decided to not require any companies to report on gender pay gaps in 2020, because they thought it would be too much to do with coronavirus contingency planning on top of it. But actually, that's really vital data that we need. So it's quite alarming that that's stopped. And actually, we have done some polling data, which actually came out today, with the Fawcett Society, with Queen Mary University of London, and with the Women's Budget Group, to look at the impact of the outbreak on time use, on various different socioeconomic indicators. And we found that to try and understand whether men and women are being differentially impacted within the UK. And so one of the things that we found most surprising is that the impact on the nation's well-being has been significant, right? With not only have we seen a dramatic drop in satisfaction with their life, right? So falling by half amongst men and women, but we're seeing women reporting high levels of anxiety, and mothers of young children are amongst some of the most anxious, right? With nearly half of mothers of under 11s reporting anxiety of a 7 on the scale of 0 to 10. We also find lots of other stuff around parents being concerned about debt and going into debt, not being able to pay their mortgages, blah, blah, blah. But these are the ones I think are most important when you think about the impact on women, is if they are in paid work and doing all this unpaid work, the additional stress that they are then suffering from is also important to consider. Another area where we see a gendered impact around health emergencies and indeed in coronavirus is around access to health, right? And so if we think about this from a sort of structural violence perspective, we know that access to resources, access to healthcare, protection of human rights are affected by epidemics, and they mainly just highlight inequitable socio-political and economic structures. So we know, as we talked about before, that there's going to be certain groups of society, such as women and BAME populations, who are the ones who are going to be most affected by changes to provision of healthcare. And we've seen this in previous outbreaks. So what we see in Ebola, what we've seen in Zika, what we saw in many cholera outbreaks, and we're seeing here, is that health systems become distorted during times of crisis. And suddenly all hospitals, all ambulances, all facilities all human resource gets moved to focus on the outbreak. So everyone is working and focusing on coronavirus, which, and there's many good reasons that they should be. The risk of focusing purely on the outbreak event is that this distortion of health services renders it that anything that's considered to be non-essential gets taken out. And unfortunately, what we saw during the Ebola outbreak, for example, was that maternal care and antenatal support was decided to be non-essential. And certainly in the UK at the moment, I think there is that consideration as well, that a lot of antenatal services are considered to be non-essential. Now, in Ebola, what happened was, and colleagues in LSE, Laura Sochas and colleagues, have done research to look at the additional additional maternal deaths that have been recorded during 2013 to 16 in Sierra Leone. And they found that actually the failure to meaningfully provide antenatal support has led to the same amount of excess deaths that died from Ebola, right? So the same amount of women died from not having access to routine antenatal and maternal support than people died of Ebola, right? Which raises a lot of questions around equity and why is it that we're more concerned about people dying of Ebola than we are of women dying in labour, for example. We also saw during the Ebola outbreak in Liberia that there were soaring rates of teen pregnancy because contraceptives were deemed to be non-essential. And we see other parts of reproductive health services, such as access to abortion, access to other contraceptive approaches, access to IVF, for example, all get lost in the wayside and people don't focus on them and they're deemed to be non-essential. And this isn't just about maternal care and sexual reproductive health. We also see, what gets considered to be essential medicines, what gets considered to be essential services, and how do they affect men and women differently. The other thing to talk about in terms of women's access to health is whether in places where you're having out-of-pocket payments to access healthcare, whether the crisis of the epidemic and people losing their jobs may mean that men and women do not seek healthcare in the same ways. We know that for routine access, women tend to not seek healthcare till later than men in certain parts of the world, and we wonder how that is also then amplified further by crisis. And finally, we do know that in the Zika outbreak and in the Ebola outbreak, that access to menstruation products was also limited and disrupted and not considered to be essential services. And we saw that in the coronavirus outbreak in the initial stages of the Wuhan outbreak in China. The frontline healthcare workers, which actually in Wuhan were estimated to be 90% of healthcare workers are women, not 70% at the global average, weren't being provided with menstruation products, sanitary products as part of the standard delivery of PPE and of equipment they might need whilst on duty, which led to a lot of, social media concern, let's say. Now, in the coronavirus outbreak, we are also seeing impacts on sexual reproductive health. So we've seen that supply chains have been severely affected, and including a range of short-term contraceptives are not being able to simply be transported. Most of the world's condoms are made in Southeast Asia. And given that was the first part where the outbreak first emerged, this meant that not only did we see disruptions in terms of production when factories were shut, but now we're seeing the added impact of trade routes stopping. And so we're seeing stockouts of contraceptives all across, well, Europe, Africa, and Latin America. There's also a demand side effect, with some women unable to visit healthcare providers to access contraception because they are either in self-isolation and don't want to risk being exposed to disease transmission in crowded clinics, or simply those clinics have shut because they're deemed to be non-essential. And this is all, and linked to this is this question of abortion regulation, because we've seen abortion regulation can be altered by the global health emergency. So in England, we actually saw what I would say is a positive step, which was where as soon as lockdown came about, after initially saying they weren't going to do it, the Secretary of State for Health performed a U-turn and actually has changed legislation during the emergency period, we don't know how long that will last for, to allow self-managed medical abortion at home with a call to your doctor rather than having to go and see your doctor in person to get the medication. So this can be seen as quite a progressive way of trying to manage routine reproductive health needs in a crisis. Now we see the opposite occurring in the United States, with Texas, Ohio, Iowa, Alabama, and Oklahoma all doing the opposite and using coronavirus and the outbreak as an opportunity to clamp down on further regulation of abortion. They have said that abortion is not essential healthcare services, and actually that all the human resource and clinic space should be used by coronavirus patients only. And so you're now unable to get abortions, at least in Texas it still remains, and some of the others have been challenged in Supreme Court and other courts of adjudication. But we can see how coronavirus is having a direct impact on women's reproductive decision making and ability to make those decisions. Another area where we see a big impact on women from the outbreak of coronavirus and the response to it is in inter-partner violence and domestic abuse, right? So we've seen that IPV has increased around the world since lockdown measures for coronavirus have taken effect. Now we know that gender-based violence, inter-partner violence, whatever you want to call it, tends to affect women more than men. So 89% of gender-based violence is against women. But this is not new, right? We saw this domestic violence occurring during the Zika outbreak, during Ebola outbreak. We know that domestic violence happens in the home. So what happens when you shut everyone in the home and you put additional stresses such as economic insecurity and concern about infection and children in the household? It doesn't take a rocket scientist to see this happening. And it's a real problem, right? So just to give you some stark contrasts, in El Salvador, there's currently been as many cases of femicide as there have been COVID-19 deaths in this outbreak. So this is a real problem that we need to take seriously when we are thinking about designing responses to global health emergencies. Now, I'm not condoning what's happening in El Salvador because the government is also making some questionable decisions, but this is a big trait of it as well. But what we can see in the government response to the coronavirus outbreak is how different governments are responding to things differently. So actually, it's been quite a great control to be able to see how the whole, the global community, every country in the world is facing the same problem. And we can actually see the effects of different policies by seeing, well, how have different governments done it differently? And when it comes to domestic violence, we're seeing different approaches. So Malaysia have advised women to dress up and don't nag, and that we're going to get around domestic violence by simply putting makeup on and not nagging your husband, which to most people is quite an alarming government response. I should add it has been subsequently withdrawn. Italy has increased the numbers of domestic abuse helplines and has set up mechanisms to report domestic violence at grocery stores and at pharmacies, because obviously people are concerned people won't be able to report. Australia, for example, has changed legislation to increase funding for anti-violence organisations, including those that are offering safe accommodations. But there's also been a lot of discussion in the literature around, should we be, in the UK, for example, they have been trying to increase access to domestic violence hotlines, but also increase access to hostels and availability of safe spaces for women and their children who feel they are at risk. But there's further discussions around actually whether we should be going one step further, and why should the victim of domestic violence be the one who leaves their home in an emergency in the coronavirus outbreak and is put into a hostel with 8 other women or 10 other women, which, by very nature means you're at greater risk of infection, because if you're in a household with 2 people as opposed to 10 people, and each of those people might be going out and going to shops or whatever, that is going to increase your risk. And so whether we should actually be focusing on taking the perpetrator out of households instead of women. But this has not been taken too far in the UK, but it has been being raised certainly amongst women's organisations. Okay, I'm aware I'm whistling through this, but I'm hoping we'll get through it all and then we can have questions at the end. So another way that we can see the impact of coronavirus on women and men differently is around the economic impact. So we know that, the impact of coronavirus is massive from an economic perspective, right? Just looking at this graph on your screen, you can see that stock markets are plummeting. We can see that all sectors of the economy are being challenged, but that we have to consider that the economic consequences of the outbreak will likely be gendered, right? And this is because we know that in most places around the world, the informal sector and low-income workers are going to be at the most risk because they lack the social protections of workers in formal economies. And we also know that informal workforce and the low-paid workforce are also more likely to be women. So this makes us think that actually, the economic impact is going to disproportionately fall on women. And the reason we think this is because during Ebola, that's what happened. During Ebola, quarantine measures, for example, closed markets, which meant that traders' livelihoods were disrupted. And most of the traders in those markets in Sierra Leone and Liberia were women. So we saw a direct impact of, a response which had a direct impact on women's economic security. Now, that's not to say that men didn't lose their jobs during the Ebola outbreak, but what I always think this statistic is quite important, right? 13 months after the first case of Ebola was detected in West Africa, 63% of men had returned to work compared to only 17% of women. So we're seeing men go back to work after an outbreak event sooner than women. So we have to think about this in the coronavirus outbreak. How are we going to try and think of longer term planning and think of stimulus packages to ensure women's economic empowerment going forward? What mechanisms can we put in place to do so? Now, the Ebola response and the reason women went back to work for so long after is multifaceted, but one of the key things was that they opened up the economy before they reopened schools. And so someone had to stay at home with children. And so I think when we start thinking about exit strategies and how we're going to get out of lockdown, we need to think carefully around how you can open up different parts of the economic sector and how that's going to impact men and women differently. So the last part I wanted to talk about today was around women's leadership and representation. So there's been a lot of discussion in the media around, are women leaders doing better in this outbreak than men? Now, it's clear that representation matters in decision making. And indeed, we know from other areas of political science literature that women's leadership leads to, or tends to, and it's not a uniform thing, there is no trait of women's leadership, but women leaders tend to be more collaborative, increased transparency, have a greater sense of humility in their approach to leadership. And so there's been quite a lot of conversations around, is that why it seems that New Zealand, Norway, Germany, Denmark, Finland, Iceland, all with women leaders, are doing better than men? And this had been highlighted prior to this coronavirus outbreak by the Global Preparedness Monitoring Board, which was a multi-stakeholder review of current capacity to respond to a major global health emergency. And one of the express recommendations from this was that there had to be more diversity within decision-making for health security, and it needed to include not just more women, but more representation of other ethnic groups as well. Now, this was only published last year, and there hadn't been much of a movement taken to actually implement this. So we don't really know actually how important representation is. We know it's important for other things, but we don't actually know, we haven't got any concrete evidence of how it impacts health emergencies. And actually, one of the things that I think is really important to when we think about are women leaders doing better in this than male leaders, is it the women leaders are doing well, or is it simply that male leaders are doing badly? And I think it's important to also highlight that not only are, for example, Trump's coronavirus task force, which you can see on the screen, only has 2 women in it. The UK's coronavirus C19 group in the government is 5 men and no women. And we're seeing this quite stark emerging story appearing between the kind of populist, character-driven politicians' response, so Trump, Johnson, Bolsonaro's response, which seems to be, pretty shambolic, compared to the success stories, which just happen to be in government led by women. But I don't think we can yet make that claim that women are doing better than men. I think it's simply that a couple of men are doing really, really bad jobs, is my read on the situation at the moment. But representation isn't enough, right? And we need to think about the right type of representation and making sure that policy that's created is gender sensitive and recognises the tensions within policy, and that policy often has unintended or secondary effects. And so we need to, at times of crisis, not focus on the tyranny of the urgent, and it's not just about getting out any policy at all. But it's recognising that, every policy and every rush decision is going to have consequences, and that we know that within health systems, it's the structural issues, which means that they're most likely to affect women and other intersectional issues more than others. But this doesn't happen by accident, right? And I think it's really important to remember that the whole of global health security, and indeed the coronavirus outbreak, is constructed in a way and to create a certain policy pathway. And that is that really fine balance that I talked about at the beginning of this presentation, looking at the tension between economic protections and protecting people. And this actually stands in quite stark contrast here, right? Most global health security policy at the global level directly talks about the impact on trade of outbreaks, directly focuses on the economic aspect of this. And so we really need to really reassess this going forward. Is this the right type of policy that we want? Is this the kind of policy we're happy with, that economic interests seem to override people? And I think that a gender analysis and a feminist approach to thinking about this is a useful analytical tool to asking those types of questions. Because what you see is that the global health policy community and global health governance is quite a masculine space, right? And so, as Acker and Freeman have said, that, globalization, this whole concept of global activities, which is, recognizing a reorganization of politics and power through capital goods and labor, is presented as gender neutral, but that this gender neutrality explicitly masks the masculinization of the macro-structural models, right? And that actually the way that everything's being created, the way that policy is created, the way that certain sectors are prioritized, such as the economy, it is actually an implicit masculinization of this space. And as Francesca said 2 years ago, that we also need to think that, who's created these institutions that then created this policy. And actually a lot of the epistemological authority that's gone into policy making, right, has been based on, historically male institutions in the West who come to this with a certain type of knowledge and practice. And I think what we're seeing really starkly in this coronavirus outbreak is that epidemiology is as the key approach, right, and the only way to think about policy making. And it's all about the numbers, and it's all about, flattening the curve and or smashing the curve, or whatever you want to say. Now, I'm not suggesting that we shouldn't do that. I'm 100% not suggesting that we shouldn't be looking at the case numbers and looking at incidents and trying to think of ways that to reduce that. what I'm suggesting is that by focusing on the epidemiology and focusing on the modelling, you're not considering, or there's a failure sometimes by that type of policy making to consider the real world impacts of these decisions. So while from a public health perspective, lockdown might be the best way to smash the curve, by not recognising the implicit effects of that and how those effects disproportionately fall onto women, you're missing something slightly broader from the decision making that needs to be included. And so what this reminds me of is some of the feminist security studies literature within international relations, and particularly a piece by Lena Hansen in 2001, which says that if security is a speech act, then it is simultaneously deeply implicated in the production of silence. And this might be a very convoluted and academic way of saying, if you don't recognise there's a problem and you don't recognise that your policy from a gender neutral perspective doesn't think about women, then you're not going to think about it, right? And, I don't think policymakers are necessarily misogynists. I generally think that they are really busy and they don't have time to think of everything. And so I really think we need to spell it out to policymakers that there are gendered effects of all policy. And within this crisis, it's been amplified. And so if you then follow on from this feminist security studies perspective that talks about this production of silence and how you silence things by not talking about them, what feminist security studies does is it foregrounds the role of women and reveals the blindness of security studies to thinking about gender, right? And how gender and security are interrelated. And almost all feminist security studies looks at, the role of militaries and gender in the militaries and gender in kind of traditional spaces of security. But I think we can also think about this in spaces of health, and particularly in spaces of outbreaks, particularly as a lot of outbreaks have been securitized. Now, one of the problems that feminist security studies has with broader issues of security is that the referent object, so the thing which is considered to be at risk, is always the state, right? It's how do we protect the state from the impacts from outside world? How do we protect them from, armies or internal chaos and tensions and conflict? But it's very much a kind of state-centric view of the world. Now, a feminist approach basically asks, well, what's missing, right? If we look at it just at the state level, what are we not talking about? And often what that means is we're not talking about women, because we know that states are a heavily masculinized space traditionally. And then feminist security studies takes that one step further and asks what this omission looks like on policies and how policies affect individuals. And my last slide, bang on 45 minutes, looks at how we can ask that question of the response to the coronavirus policy, right? So if our question is, what impact does the omission of thinking about women have on policies for individuals? Well, I think it has a lot. And I think if we put women at the center of the decision making, and I don't mean that necessarily by putting women in decision making roles, although that would be great, I mean making sure the explicit understanding that policies, that the response to coronavirus will affect women and men differently, will lead to a different type of response. So, for example, it might, if you put women at the center of the recognition of the impacts on women of the outbreak at the center of decision making, it might focus on frontline healthcare workers, who are predominantly women, and ensure that care work is incorporated into economic decision making, right? So how can we ensure that is recognized? Can we pay them more, for example? Can we pay our frontline staff more if we're going out and saying that they're so important, right? I think particularly, going out and clapping for the carers is almost a bit insulting if you're not also thinking about how to ensure that their efforts are recognized financially. Can we ensure that we get sex segregated data made public for all aspects of this outbreak to ensure we can actually talk about how men and women are being differentially affected? Simply that policymakers need to recognize the gendered effects of the response and make sure that resources follow to mitigate against some of those secondary effects. Can we ensure access to sexually reproductive health services at home or at pharmacies without needing to have a prescription? Can we rethink the mechanisms of delivery for routine reproductive health? Can we ensure that all intimate partner violence support is financed and make sure that that's equally part of the response activity? And then thinking in longer term about how do we get out of this situation and exit strategies, and which sectors of society are we going to open, or of the economy are we going to open first post lockdown? Now, in the last crisis we had in the financial crisis, it was, the male-dominated industries which were the ones that were bailed out. Now, I think we're going to see widespread economic fallout from this outbreak that we're already seeing. And it's not just about who gets open first, but which companies survive and which sectors of the economy are then bailed out by governments. Now, I think there'd be I think a lot of, for example, care businesses will not be able to survive going forwards. Whether that is private care homes, whether that is nursery sector, for example, they are all female-dominated industries. Are we going to see the same support to those industries as we are, for example, of, city financiers? So I think the government could take some interesting, or any government could take some interesting approaches to thinking about longer-term strategic planning for the economy going forward. And I think they're only going to do that if we are recognising that we need to have gender advisors on decision-making bodies across policy going forward for this, not just in the health sector, but in all aspects of decision-making and scenario planning for the post-COVID world. Are there gender advisors asking these questions, and are they given a seat at the table? And, is there a way we can ensure that these questions are being asked of policymakers to try and ensure that we get a more equitable response and going forward?